Hello, hey Tim, come on in.
In Royal London Hospital Theatre 2, 51-year-old Tim is about to have surgery to remove a tumour growing in his large bowel. We'll be showing you the entire operation live as it happens. Tim was anaesthetised just before we came on air, and in just a few minutes, lead surgeon Shafi Ahmed will start the operation.
Another 2 big breaths, deep as you can.
Okay, can we just stop for 1 second and we'll just do a quick team brief, everybody, while we're here? So this is obviously a patient who's having a lateral right hemicolectomy, and we'll do the team brief very quickly. I'm Shafi, I'm the surgeon.
I'm George, I'm the surgical SHO.
RT surgeon.
Joyce, circulating nurse.
Pam scrub nurse.
Anthony surgery. John surgery.
Tracy, HCA.
Norman, ODP.
Try anaesthetist.
Okay, patient's name, date of birth, and MRN, please, can you confirm?
Well, here in Theatre 2, final preparations ongoing for Tim's surgery. Tonight's operation being performed by consultant colorectal surgeon Mr. Shafi Ahmed and his team. Now, Shafi's one of the leading colorectal surgeons in the UK. He's going to be guiding us through what he's doing, when he's doing it, talking us through it, and they're making their final checks ahead of the operation. With me in the hospital grounds in our broadcast truck, another of the UK's leading colorectal surgeons. Good to see you, Jamie Murphy.
Thank you, Nicky.
So when Shafi is really concentrating and is able to speak to us, you're on standby to tell us exactly what is it going on exactly?
So essentially what Shafi will be doing is beginning the operation. He'll make some incisions, place some graspers and instruments through the abdominal wall itself.
What's a grasper?
So basically they are instruments that allow him to manipulate the organs inside the abdomen. He will then free the colon up. He'll make a cut in the tummy wall. He'll deliver both the colon itself, the large bowel, and the tumour within it out for you to be able to see. He'll remove that, join the bowel back together, and close the skin.
He will take the bowel out and put it where?
On the abdominal wall itself.
So
you will be able to see it during the operation.
Fully exposed?
Indeed.
That'll be an extraordinary thing to see. That's coming out. We had mentioned there, Shafi, the name of this operation.
Yeah.
Shafi said what? It was called
right hemicolectomy, so removal of the right side of the colon, the large bowel.
Okay. More to come from you, as we can see. They're getting ready there, and all surgery has its risks. This surgery is a massive operation for Tim.
Good. Imaging not required.
When I first heard that there was a tumour or a polyp, whatever you want to call it, I was quite shocked. It was completely unexpected and completely out of the blue. My family, my friends, they're all supporting me. All very concerned, obviously, that everything goes well. I've gone into graphic detail with my family. Oh, this is it. Do you want to see it? Shall I send you an email of it? I don't see there's any point in hiding behind things. And I think they need to know what the potential is.
Okay, so George, this is the man's CT scan, and you can see the large bowel here. As we come down a fraction, you'll see this tumour appearing here, which measures about 3 centimetres in that part of the colon, which is the right colon. And so what we'll be doing today is taking away that part of the colon and doing a right hemicolectomy and joining the large bowel to the small bowel to allow that join to take place. That's the operation. Otherwise, the CT scan, the rest of it is all clear. No signs of other disease in the liver or indeed the lung. It's all clear. So that's what we're planning to do, George. That's okay?
Yeah, it makes sense.
Well, Shafi mentioned the tumour there, Jamie.
He did.
A tumour doesn't necessarily mean cancer.
No, the word tumour simply means a growth. Some growths are cancerous, some growths are not cancerous, but until it's been removed and sent to the laboratory, we won't know whether or not this is the case.
And also, they're still getting Tim ready for surgery. What exactly is happening at the moment in there?
So at the moment, what they will be doing is positioning Tim on the bed, as you can probably see at the moment, how he will need to be for the operation itself. Once they have done that, they will clean Tim's skin. They'll then go on to clean themselves and put the sterile drapes on Tim.
Yeah. Jamie, tell me about the keyhole surgery.
So keyhole surgery is a technique where we make small cuts. As we've already said, we put instruments through these small cuts, and they allow us to move the organs inside the abdomen. However, ultimately, we will have to take the bit of the large bowel out with the tumour in it, and so there will be a larger cut later on to do that.
Incredible teamwork. Everybody has got a crucial role to ensure that the operation goes smoothly and that Tim stays safe.
My name is Shafi, and I'm responsible for the care of the patient that we're dealing with today, and I'm going to perform the operation. So next to me is my assistant called Arti, who's a senior colorectal fellow specialising in keyhole surgery, and she'll be my main assistant, holding the camera and supporting me during the operation.
You're operating no matter 10 hours, 15 hours, you're still ready for the next case. You know, when you are washing your hands, putting on the gloves, all tiredness leave your body.
So on my right-hand side is the anaesthetist, whose job is to put the patient to sleep, make them relaxed, ensure the pain is under control, and monitor all their vital signs during the operation.
I feel very fortunate in that I love what I do. I've had a lot of hard days, we all have, but I have never had a day where I've not wanted to be there or I've wanted to do something else.
So the other person next to me is George. He's my junior surgical trainee, and he's the person who will support us during the operation. And also he's someone that we can teach so that he can learn and one day become a senior surgeon.
It can be quite intimidating at sometimes. A lot of the time it's very intimidating. I think when you come into theatre, you know, you're immediately a little bit nervous because you know big things happen here.
So the next person is Pam, who's our senior scrub nurse. And her role is to ensure that all the instruments are sterilised and correct, and to handle those instruments that are required during each part of the operation.
You have to be strong. Sometimes you get emotional. So when you go in theaters, I think it's better to be strong and don't deal with emotions, because if you deal with emotions, you can't do anything.
We're going to see the first cut, as you say, near the belly button very, very soon.
Yes.
What's the atmosphere like in there right now?
Everyone is focused on their own task. Obviously, they're working together as a team and they're communicating very well. But ultimately, everyone has a role to play. And at the moment, that's what they're focusing on. And you can hear very little discussion other than that.
And how are you feeling in there as a surgeon, as a consultant?
I think you're always confident, you're relaxed, you've planned the operation, you know how you're going to do it, and then you just have to execute your plan.
Yeah. We heard from Chaya there. Tell me about the role of the anaesthetist.
The anaesthetist is obviously crucial in these cases. The anaesthetist's job is, first of all, to put the patient to sleep under general anaesthesia, and then after that is to keep them safe. They'll be looking at the lungs and also the heart function, and essentially keeping the patient alive during the operation.
It's an incredible job. We are in Theatre 2 at the Royal Hospital London, where 51-year-old Tim is about to have a tumour removed from his large bowel by surgeon Shafi Ahmed and his team. Jamie Murphy, is this a pretty routine operation?
It is routine. I mean, on average, about 10,000 of these operations, this kind of operation will occur each year in this country. But obviously, each one is slightly different, and Shafi has had to look through the CT scan to plan his operation accordingly.
What's the scale of what you actually see on the screen, which is being picked up by the camera in there?
So the camera will magnify 2 or 3 times greater than you would see in real life. So the images you're going to see on the screen when Shafi blows up the belly with gas and places the camera in will be bigger, obviously, than in real life.
Right now, there are a lot of wires going across and a lot of preparation is being done before the first incision. What exactly is happening there?
So Shafi is now setting up the equipment he's going to need for this operation. You can see various devices being brought out and tested. He's making sure that they're in working order and that they're set to the appropriate settings.
And the operation of the camera is such a skilled, necessary component in all this, isn't it?
100%. If you can't see the organ you wish to operate on or remove, then obviously it's impossible to do this operation.
Yeah, so what are the big challenges of this procedure?
So this procedure, Shafi will enter the abdomen, make sure the scar tissue from previous operations can be released so he can get a good view. He will then obviously have to make sure that there's no bleeding, and you'll see later on in the programme how he manages that.
Do you ever lose your sense of awe when you see inside the human body?
I suspect we all get used to our day jobs, but every now and again you still get caught by it.
Yeah, it's an incredible world in there, isn't it?
It is indeed.
Yeah. So when you're in there, is there a lot of fat? Is there a lot of other tissue that you have to cut away?
So you will certainly see when Shafi puts the camera in, the first thing you will see is a fatty layer. And so Shafi will move that away, assuming it's not scarred to other structures, because he may have to cut otherwise.
Well, the patient is ready for surgery.
Thank you. Okay, can we have a knife, please? 2 little ones, please. For that. 2 little ones. And a clip. So thank you. 2 little ones in here. Thank you very much. That's great. And a clip. And then the 10 port. Thank you very much. So we're going to now just try to enter the abdominal cavity. This is the kind of head end. This is the feet end. And here we have the umbilicus. He's had a previous operation. So we've had a previous surgery just here. So what I'm going to do is just lift that up. Like so. And then hopefully just go between the 2 of them to make the cut. Okay, to start.
Yes, thank you.
Chaya, thank you very much. Okay, everybody, here we go. So incision going in this way. I'm just going to gently open up the umbilicus. Clip, please. He did have a kind of a small hernia, I think.
Good.
So here we go. Can we have the 2 Langevex, please?
Yeah.
There we go. And the other one, please. Thank you very much. So he's had a previous gallbladder removed a few years ago, done through keyhole surgery. So we're going through the same incision they made before. There's a bit more scar tissue to get through. Just gently do that for me. And what I'll do now is just get that there, thank you. And let's get the 2 little ones. No, let go. It's okay, let go there. Swab, please. Get that for me. And give me that. Thank you very much. Just a bit of a dab here. I'm just going to gently open up the cavity just here. Hold that for me. A knife again, please. Pam, thank you very much. So now we're going through the scar tissue, just to try and get through into the abdomen here. Let's have a little clip, see if you're in. Thank you very much, Aarti. And it looks as though it should just be in soon. There we are, there we're in. There's a little pop that goes into the abdominal cavity. We're going to open that, stretch it out a little bit, which allows us to put the port into the abdomen. Let's hope it's big enough. Let's just have a look. There, good. Thank you, everybody. Take those clips away, knife away. Thank you. Can we just check we're in the right position, Aarti, with the camera? Yeah, that looks like fat. Okay. Now, can we get the gas connected, please? So now we're using CO2 gas. This will inflate the abdomen so that it gives us space to do the operation. Otherwise, it'll be flat and all the organs are close together. Yes, please. Let's go. You're happy with the breathing for us to do this? Thank you. Pressure. One second. Yeah, and as you can see now, immediately as you put the gas in, the abdomen becomes swollen in all parts uniformly. So we know in the right place. And we measure the pressure at 15. Good, and flow's good. So now we're going to pop the camera in. And this is the first look inside Tim's abdomen. So here we go. Let's have a gentle look. Here we go. This is always an interesting part of the operation when you see what's inside first of all. What surprised a lot of people is, of course, is this fat that you see, the yellow structure that we all have as we enter the abdominal cavity. And that is a kind of protective bit of fat that stops lots of nasty things happening to us. And I'm going to show you a bit of the anatomy here. So here we go. This is the liver. You can see that brown thing. Yeah, as you can see, the camera itself becomes a bit unclear because of condensation, because it's a warm abdomen but cold camera. So we're just going to warm it up, and we touch it a little bit, and with some anti-fog solution. So we can use that, and also warm the scope as we go in. And we can see a bit more clearer now. So that's the, well, here we go, it's clouding up again. So we just wait a little while for everything to warm up nicely. We can use the fat and do the liver to clean it and keep it warm. Okay, so now you see this brown object, which is the liver. That's the right side of the liver. And it's kind of in two halves. And the other side is underneath this bit of fat here. And this is the left lobe of the liver. And here, just next to it, is the stomach. This kind of red structure with lots of arteries and veins on the center of it. What's really interesting, of course, you can see the heart beating through the abdomen into the chest. So obviously we had live surgery the other day, which was cardiac surgery, but we're on the other side of the chest into the abdomen. Over here will be the spleen, an organ right behind it, which you can't quite see, but it's tucked behind that fat. As we come down now, and so what I've noticed is nothing abnormal seen so far for Tim, which is always a good sign. Now we look down in the pelvis, and now we see the small bowel, which is this, compared to the large bowel, which looks like this. As you can see, the large bowel has fat around it like this, the small bowel doesn't. And also, we now see the appendix right in front of us, that long structure, the white thing you can see all the way here, is a long appendix. What it helps us to do is find out where this tumour is. And this tumour is going to be here, around where the appendix hits the large bowel over here. Next thing we need to do now is put the other ports in. So we tend to put some more ports in to help us visualise things. And we're going to go here. And in fact, you may... OK, let's just go in here. Let's have a knife, please. Thank you very much. 10. So we use direct visualization for these ports. We can see what we're doing. And we're just going to pop it in there. So hopefully you can see as it goes in into the abdomen. There we are. So it's just protruding in there, safely away from any bowel. There we are. It's just pushing through. A bit of fat now through. Now just a bit more push. And we can see it coming out just there and in further. So now we're in with the second port, and that's good. That gives access. Again, it's been done safely using direct visualization, and that comes out there. So these are for instruments. These ports that we put in are for accessing other instruments. Obviously, we can't do the operation just with the camera. We have to have lots of instruments and go through these ports, including mechanical devices like staplers and things, which we'll show you a bit later on. Let's have another knife, please. Here. Move this out the way for me a little bit, please. Thank you. Just going to just make a little incision here. Thank you. Now we're putting a smaller port in here for small instruments. Here we go. There we are. As you can see, we can see what's going on. And we're in again, very safely, ensure we can see what we're doing and not damaging any important structures. Okay, the next thing we're going to ask Chaya is whether we can have some head down if he's able. If his breathing is good and we're happy with that, we'll try to give him head down slightly.
We'll give it a shot.
And gravity moves things out of the way. We need space to do the operation. We use simple gravity to pull things out of the way.
Also, bear hug's going to go up,
Good.
okay.
And the right side up, please. Good.
Happy with that?
Thank you very much. Can you come on this side, Arti? Right, let's have some instruments. Let's just give it a clean. Again, keep warming it up, making sure the picture's clean. And here we are. That's clean as. Okay, thank you very much. Can I have those, thank you very much. Can I have those two lights off, please, on top now, please. Thank you. These two lights off, thank you. Just those ones, thank you very much. Okay, so now we're just going to see what we can do in terms of finding the right area. So what we've got here, come in, Arti. So as I said before, this was the appendix. It's a great landmark. This is the thing that often gets inflamed. A lot of people, that has to come out, but this is obviously not in this case. It would come out anyway during the operation because we're moving part of the colon. If we come over here, Arti, I'm just going to move the fat out of the way gently. A bit more to the right, please. Come in with the camera slightly, thank you. Okay, thank you. So all we can do now is hopefully come back to the bowel here, is try to usher the bowel out of the way a little bit gently so that we just get space to find out. Okay, so here we are. This, in fact, is an interesting point. This is the small bowel here going in to the large bowel. And Tim's tumour is just around here somewhere. We might not be able to see it on the outside because it's more inside. Sometimes you can see a big tumour sitting here, but his is much smaller. So we're just going to push this out of the way gently, see if we can access some of that area behind it. George, can you just push that, this light just away slightly? Just push that just gently out of the way. Without touching anything else. Thank you, that's good. Thank you very much. In you come, Arti. So we're just going to have a look around this area. Keep down here. Arti, to the right, please. Thank you. So that's fine. That can still stay there. That's... Sure, of course. So down here, Arti. Thank you. Just going to feel our way around this area first. Find out. So first of all, the fat is here. It's a little bit attached, as you can see, by a few fibres, which may need to release. Pressure's at 15. Yes, thank you.
Talk us through what you're seeing at the moment.
So essentially, Shafi has the camera in the abdomen. He's now assessing how the structures relate to each other. At the minute, Shafi has a strand of tissue. You can see that he's picked up with the metal grasper, and he's now going to use a vibrating device to cut this strand in order to release the fat from the large bowel. Shafi will then lay the large bowel out and identify exactly where he believes the tumour is, and he will then start to release the large bowel from the other structures in the abdomen.
So these access points, these holes, these ports, I think he referred to them as ports. How many will he be making?
So he has placed 3 at the moment, and sometimes for a right hemicolectomy, removal of the right large bowel, then that's adequate. But obviously there is a degree of scar tissue within the abdomen from the previous operation, and so if Shafi feels that he needs to place a 4th or a 5th port to give him more access to the abdomen, then he may have to do that.
And the appendix is coming out?
The appendix actually dangles off the first part of the large bowel. And so because the tumour is downstream of that, then the appendix will come out automatically.
Let's sit down here. Come back a fraction with the camera. Yeah, so can you see? Can you come back with the camera? Okay, so show me just down here a little bit, further down. Okay, so what I'm going to try to find is the artery that supplies this part of large bowel. All we do is just lift up this fat here gently. Hopefully as you lift it up, you'll find an arch here, which is where the artery is. Just going to try to push a lot of this bit of, just trying to push that out of the way there a little bit, and a bit more here. Just a bit stuck. Let's see if that's, oh, that's stuck. Okay, that's back. Come back down here. Just down here. Just right down here. Do you want to hold the camera for me, George? Do you want to come between the legs? Might be easy for you. George, you come to this side. I have to come over here. It might be a little bit easier for her with the arms. Thank you. Thank you. Come back, show me. Come back.
How much of an issue is the scar tissue from the previous operation that Shafi was referring to, Jamie?
So Shafi is now encountering that at the minute. The scar tissue we saw earlier was the fat stuck to the liver, and because the fat is also stuck to part of the large bowel, that's impeding Shafi identifying the area he wants immediately. So it's going to take a few moments just for Shafi to be able to line things up so they can then begin the rest of the operation.
Okay, so we're just finding the vessel in here, which is just going to be in here, in this fold. And can we have a mastoid, please? Thank you. It's going to use a swab just to use a bit of friction on it to keep things out the way. Here we go. So here we go. One mastoid inside, thank you. What we're going to do is use the mastoid swab, like this little swab here, which will just use a bit of friction to keep things out the way for me, hopefully, so I can do the operation. Here we go. Now let's go back here. So I'm just going to push that down a bit. Just going to push that gently out the way, just touching everything a little bit. Yeah, that's good. That gives me a little bit of space and also provides a protection for the bowel. Harmonic, please. Now I'm going to try and find the vessel in here. I'm just going to do a little bit of work here. Just at the extreme of that bit there. So we can just, hopefully, just come up a second. Just if I can just do that a little bit. Just, there's a bit more touch. Okay. Can we come here? Perfect. So now we will see tiny areas we need to get into, the membranes, if you like, around the artery, which I'm just doing here now.
Jamie, tell me a little bit more about that tool, that cutting implement.
So this, you can see the metal device opening and closing and dividing some of the fat. This is a device that vibrates at 50,000 times per second and actually destroys tissue. It both seals the tissue and also cuts. And the steam you can see off it is literally the water coming out of the fat tissues.
How close to the artery is it cutting?
So we cannot yet see the artery, so Shafi has been dividing the fat over the artery itself. We can only see the imprint of the artery, but we will in a little bit see the artery itself.
The fat in there, it's not fat that's surplus to requirement, that's necessary fat in there, is it?
All of us have that fat. All of us have that covering of fat around the blood vessels that supply the bowel.
Right, we'll be able to have a look at the artery for the first time very soon. And that instrument that's burning the flesh, that's creating a smell that you can get in the surgery.
You can, obviously, at the minute, all of the gas is being pushed in and withdrawn through the ports, but later, yes.
Tell me about the precision needed to cut the artery, which we're about to see.
So, as you will see, there's a great deal of precision required. The artery needs to be both crushed and also cut. And if you fail to do that accurately, then obviously you could have significant bleeding.
Can you give me another, it's just not grabbing, can you grab them please, just while we can take that.
Before we cut an artery, I think we make sure and then make doubly sure. Otherwise, there will be troublesome bleeding because these are big arteries.
So you're limited by access with a camera. So if it bleeds, for example, and the blood takes away some of the light because it absorbs some of the light, then your eyes are impacted immediately. You see much less and less. We take our time to ensure that we're safe, that we're not doing any damage, because it's a vital part of the operation, and sometimes slowing down that point is the right thing to do. Okay, so what you can see now is the artery just in my hand here. This is the artery. We've gone around it to make sure the other bit of bowel is safe underneath. And now just come back a fraction, Arthi, and just show me. So now you can see my instruments all around the back of it. Now we're going to staple that with a stapling device. So I'm going to get that out now, thank you. Thank you very much. Can I have a Johan, please? Thank you very much. Do you want this one? No, I'm good. Just going to have a look at that. And here. Thank you very much. I'm just going to see if I can just get more space out this way here. Thank you very much. We're now going to hopefully introduce a stapling device, which hopefully will allow us to lift this up, like so, turn it upside down, then hopefully we can go across the vessel. Just going to gently tease into position, which is just here. Just go off a little bit with you. Just keep in view. Yep, thank you. Go down. There we are. We cross. As you can see now, come back, bigger picture. There's the artery. We've got the stapler either side of it. Come back a fraction, Arthi. I'm just going to move the fat that way slightly. I'm going to move the artery across here. And then take everything out of the way so that we can now clamp the artery. Here we go. One second, hold that for me. Use both hands to clamp it. So now we've clamped it. What that allows us to do is fire staples either side and to cut between the two. But to control it, I just want to put a device just in front of it over here. So if it does not work properly, I have full control of the artery because it will bleed torrentially if we can't control it. This is a critical part of the operation. Can we do that for a second? Okay, now I'm going to fire this, and we shall see it being fired. You see that stapler going all the way across. Come back. And now, what we do is we just keep it held. We'll release the stapler. Gently. As you see, it's put staples across both sides and sealed the vessel. We can take this one out now, thank you. Give me another mastoid, please. On your hands, please. Yeah, I'm very happy. We've got control, and that's the most important thing. It's not bleeding, and we have a nice staple line across. I'm just going to always just soak up a bit of the blood using some swabs so it becomes even more visible and clear. Thank you.
That's a remarkable bit of equipment, that stapler.
It is, it is.
Yeah.
These staplers are critical to bowel surgery.
And he said there was the possibility, which hasn't eventuated, of, I think Shafi described it as torrential bleeding.
So these are mechanical devices. They're very high fidelity. They're produced to very high standards. But every now and again, Either technical issues or mechanical issues sometimes can mean that you have bleeding that is difficult to control.
Can that be used again, that particular piece of equipment, that stapler?
In this patient, it can be reloaded, but they are used only for one patient and disposed with afterwards.
You mentioned a mastoid. What's a mastoid?
So a mastoid is the white bit of gauze that you can see on the screen here, just to allow him to mop up some of the fluid that's there.
Are those swabs always necessary?
They're not always necessary. There is a bit more scar tissue in this operation than usual, and Shafi's just having to use them in order to make the operation as safe as possible.
And having to be so careful when he's cutting. The artery has blood under pressure. If it's damaged, bleeding will be rapid and extensive, torrential, as he described it.
The margins are really fine. It's really hard to describe how fine those margins are in surgery, but it's only a few millimeters. It may be only 1 millimeter from being in the right area of tissue dissection to being in the wrong part of dissection and damaging important structures like blood vessels, like other bits of bowel, which can be catastrophic.
Shafi makes it look easy. And you look at someone doing an operation like that and you think, am I ever going to get to that stage?
Okay, so as you can see now, we've clipped the artery and we've controlled it. We were happy with that. It looks pretty good. I'm going to put another port in here, just for more access. Knife, please. Just give me more help at the top end of this operation, just here. Just going to pop this like so. Thank you very much. We're going to now just pop that next one in. Again, direct visualization, so we're absolutely safe. Good, and there we are. Thank you very much. Lovely. Let's have the two Johans, please. Hold that camera for me. Thank you very much. Let's have a look. Now let's see what we are. Now that I've just left the swab for a few seconds to soak up any blood that might have come through. Can we give a Johan to him, please? Let me give that to you here. What we need to do is just grab that for me and just lift it up for me just there, so I have more space. So this kind of surgery is best done with 2 or 3 hands. Here we go. You always need assistance. It's never about one person. Hold that there, just like that. Thank you very much. Okay, let's have the other Johan. Thank you. I'm just going to now check, make sure the vessel's all okay before we do the next step. I'm just pushing that out the way a little bit here. We're good. So what we've got now is the 2 swabs, which I'll take out because we don't want to leave swabs behind. I'm just going to take that one out first. Thank you very much. That's that one.
One swab out.
One swab still inside. Come in a fraction. Okay.
Removing the swabs.
Thank you very
He
much.
is removing the swabs at the moment.
Good.
And it's critical that you know
Thank you
which
very
ones are
much.
going in,
That's
which ones are
the
coming out,
artery done.
and
We're
count at the
happy
end
there.
is
That's
correct.
all controlled very
And he's just
nicely.
created a fourth hole, a fourth port. Why?
He's created that because this is a slightly more difficult procedure than usual because of the scar tissue from the prior operation. But it's proceeding very well and with no concerns at the present time.
And the fact that the bowel is about to come out of the body, and we will be able to see it, for many people watching, that will never have occurred to them. That will be the situation in an operation like this. It's quite an extraordinary thing to see. You're used to it.
Of course, but it is extraordinary. I take that point. Shafi now has to free up the layers and release the bowel, and then we'll be able to see that.
Okay, so what we're seeing here is that we're now going underneath the vessel, dissecting out the flimsy tissue, so we can we mobilize the colon. And just in here is the other structure that can get damaged, which is called the duodenum. It's part of the small bowel, just here, and that's we have to be very careful about when we do this dissection. And we're happy. As you can see, it's all pretty clean. There's not much blood at all here. The vessel's controlled, and we're happy, which means we can proceed to do the rest of the operation safely. So just keep going. Let's just keep going up here, guys. Just if you just give me a little hand in here. There. I'm just grab 1 second. I'll just grab 1 second. Get underneath here. Just just come into flexion, Artie. Come in the camera. I'm just going to keep dissecting here and keep going down here. There's the plane. There's a beautiful plane there. Okay, we're going to keep going all the way up towards the liver. Keep going, bring everything down. So this just was flopping the whole time. It wants to come into the picture. Okay, don't worry, we'll keep it under control. In you come, Martha, all the way in, please, all the way. Right, come in, keep going, all the way, right in here. Just here, thank you. Keep going. So we're really quite high now, aren't we? We won't do much more than that. I'm happy with that. And we're kind of clear on the medial side, so we're happy. So now we're going to mobilize the colon. So let's start with the appendix, shall we? So this, thank you.
Obviously, when you're dealing with the bowel, there's a very dangerous chance of infection.
There is, but as you will see later in the operation, Shafi will divide the bowel with a similar stapler to you have already seen to minimise the risk of any spillage.
And then mobilising the colon.
So basically what Shafi is doing at this point, and as we'll see in the next few moments, is he's freeing the colon from the layers underneath by dividing the connective tissue with the devices you see on the screen.
You hold the camera. Good, thank you, Artie.
It's just remarkable things to experience.
Surgeon and the assistant, they have to be in sync. Like the assistant role is also that they are operating through what they are showing.
You're only as good as your eyes. The camera are your eyes. So whatever it can see, you can see. If you can't see anything, or the camera can't see anything, you can't see anything either.
Sometimes you're not just holding the camera itself. You've got something else to do with the other hand, and you've got to pay attention to the scrub nurse over there, and you've got to pay attention to what Shafi's doing. So holding the camera is never quite just holding the camera.
It's really valuable having a really skilled surgeon who's an expert camera specialist who can hold the camera and help you during that surgery. Down. Lovely. Okay, so what we're doing now is what's called mobilising the colon, making it free from its attachments or the membranes that attach it to the abdominal wall, if you like. And we're just trying to get around here at the moment. In you come a little bit for me, Artie. Pull, keep pulling. Artie, grab that for me. Yeah. Thank you, Artie, it's beautiful, thank you. It's great traction, thank you. Thank you. Just here.
So we're just monitoring all his observations, so his heart rate and his blood pressure and ECG, and also his ventilation and the mechanics that are going on in his lungs. With the change in position going head down, you end up with increasing the pressure in the abdomen quite a lot, and that could put quite a high pressure on the lungs as well.
Head up for a little bit.
Head up, and we're going to reverse all that now. Going head up.
We're trying to give the patients the breather from the...
Thank you. Is that okay there? Or head up completely? A bit more? I'll do. Okay. And changing the position of the head then gives the lungs more space so they don't need quite as much pressure to be able to inflate them. So hopefully this will make the physiology a lot more, slightly more normal than it would otherwise been. The other things we've got on is we've got this thing, which is a bear hugger. It's basically a blanket full of hot air that blows over the patient, because patients get very cold during an operation. It's cold in theatre as it is, and then there's also the loss of the ability to regulate your temperature when you're unconscious. So that's what all this is, and a few other bits and pieces to keep him safe. Reduced risk of infection, reduced risk of getting clots and things in the legs, all precautions to make his perioperative pathway a lot smoother.
What kind of lengths of tissue was that cutting machine
So
cutting.
you have to appreciate, obviously, that this is magnified. That device divides between 5 to 7 millimetres, so it's a very, very precise dissection that Shafi is performing.
Yeah. What are we going to see next?
So Shafi is going to continue to mobilise the bowel until it's totally free from its attachments, from the layers underneath. And at that point, he will then be in a position to make a cut in the belly wall and deliver the bowel and the tumour into the outside world.
We'll be watching that very soon.
Let's release that. Yeah, sure. So guys, here we are. We're just going to get this out a little bit further. So actually, this is not too bad, is it? We're almost around the hepatic flexure, right? So this is pretty good. He's been kind so far in that sense. Let's just see if we can get around this last corner. It's a bit stuck up here, isn't it?
We are at Theatre 2 in the Royal London Hospital, and Shafi is partway through mobilising Tim's bowel. Jamie, progress report.
Very good progress. I mean, Shafi has already divided the artery to the bowel very nicely. There's been minimal bleeding. And now Shafi is mobilising what are the last attachments of the connective tissue between the layers that will free the large bowel.
And Tim's body is presumably still reacting to everything that's happening, and that's where Chair, the anaesthetist's role, is so important.
Exactly. You've already heard the consultant anaesthetist describing the issues about breathing with regard to the position changes, and obviously she's keeping a very close eye on these matters.
Yeah, to mitigate the pain resulting from trauma of surgery.
Come back. Show me the right colon.
When you say going to sleep, you're not putting a patient to sleep, because otherwise you would be woken up by people poking you in the belly, which doesn't happen. So what it does is you're bringing about a state of unconsciousness so that your brain is unaware of what's happening. However, all your other physiological functions of your body, your heart, your lungs, all that kind of stuff still works. And even your pain receptors will work. So all of those need to be managed. To be able to take pain away from someone is a huge privilege because, I think most people would agree that you could probably put up with most things if it was painless. So a lot of the anaesthetist's time, both during and after the operation, a lot of our attention is spent on trying to make them as comfortable as possible. Seeing them just before they become unconscious, unable to look after themselves, and being aware that I'm now there to look after them at the time that they can't do that is huge. It's a really important part. It's a job that I feel very privileged to have. It's an important part of the job.
Okay, so that's pretty good. So cecum's up, small bowel's up. Go transverse colon again. So this bit here. This is the appendix. As you see, as it goes in, the tumour is sitting just inside here somewhere. We can't quite see it, but it's in there on the scan. This kind of bulky parts of the colon, like a big sac, is called the cecum. Each part of the colon or the large bowel has different names. This is just the name for this part of the large bowel itself. So I'm just going to come back underneath myself. 1 second. Underneath. Yep. In you come. Just keep moving. Okay.
9 o'clock.
9 o'clock.
Okay, now can you show me transverse colon again, guys? Transverse colon, let go. I'm just going to see, lift up the momentum for me again. And we're just going to see how much more we've got to do in terms of mobilisation. We shouldn't be too far off now from finishing the mobilisation. You can never do enough, of course. We've learned that by many years' experience by making mistakes by not taking enough of this dissection. So I'm going to take more and more to allow me to bring the bowel through the abdominal wall.
Can you turn the clock to 12 o'clock again?
12 o'clock.
We're going to see it come out, Jamie.
Yes.
And then later on, miraculously, for so many of us, it's going to just drop back in.
Exactly. So Shafi is going to remove the affected bit of the large bowel. He's going to join the large bowel and the small bowel together, and then effectively gravity will allow him just to drop it straight back in.
We're very close to the bowel coming out.
We are.
Well, once this part of the operation is complete...
Okay, let's just see how much we need to do now. So that's pretty good. I'd say that's mobile. That's going to come. There's a few fibres just here to do just here, which I can release now.
I've been a teacher for 25 years. When you just see somebody get something for the first time, when you see their faces light up because they can do something they couldn't do before, that's the most rewarding thing. Thank you very much. But recently I've decided that I want a break, a change. I think I need something new, something challenging, something different. I don't know what yet. But this tumour sort of stopped everything, and we just need to get rid of it and then start moving on. I first went to the doctor with backache, and they said, "Oh, do you feel this? Have you got this?" They did ask me about bowel movements, which I found quite odd. But I suppose thinking back, yes, I did have irregular movements, but you don't think about it on a day-to-day basis. You just think, oh, maybe I've eaten a dodgy curry or something. And that's when they found this growth. So it's all very sudden, very shocking. I feel really lucky that the doctors were that vigilant, and that careful in their treatment of me.
Here. Okay, fine. Good, that looks really good.
Where Shafi is going to be able to remove the tumour that has been affecting Tim. We had Tim very movingly talking about that. I want to talk to you about the symptoms of what was happening to him and how it was affecting him in just a second. But tumour, we just got to remind people, I think, it could well be benign. It doesn't necessarily mean cancer.
Until such times as this has been sent to the laboratory and looked at under a microscope, we cannot say definitively one way or another.
So, we heard a little bit about Tim thinking, well, maybe I've just had a dodgy curry. What are the symptoms?
So the symptoms are obviously changing your bowel habit, bleeding from the bottom, as it can sometimes be in the poo as well. You can have anemia, low blood count. You can have pain or even a lump that you can feel in your own tummy.
All the swabs are out?
Yes, all my splints are.
So where we are now at the moment with this operation is we've obviously taken the vessel, you saw earlier, we've mobilised the entire colon, so now you can see it's really quite floppy or move into any direction I want, and that's important to be able to bring it through the abdominal cavity. That's all finished now. I've just put a little gripper on the kind of fat, and now we're going to make a small incision in the abdomen to bring out all of the specimen and to be able to take away the tumour for Tim. Okay, can we let's move on the side for a second. You can take the camera up for one moment. Oh, actually, thank you very much.
Where's the arm?
Yeah.
So what are we going to see next? How close are we to actually seeing the bowel on the body?
We are very close. So Shafi is going to make a cut of several inches through the tummy wall itself. He'll then put a plastic device in which he will roll up, which will protect the wound, and then he will deliver that part of the large bowel that he's freed out into the outside world.
We're at Theatre 2 at the Royal London Hospital. Tim is being operated on. Surgeon Shafi has finished mobilising the bowel. He's about to take it out and put it on Tim's abdomen, and then Shafi can start cutting out the tumour.
We're just now ready to make the incision to allow the bowel to be exteriorised, to be able to remove it. So here we go. I'm just going to just use this diathermy coagulation to cut the skin. I'm going to make a very small hole. Thank you. That's really good. Can we try that for me? That side. Thank you. Are you on the? Are you on there? Gas off, please. Yeah, gas is off, right?
No, that is
Good, thank you. Here. Are you on you? Yeah, I'm on you.
you're on.
Okay, take it out, take it out. And so all the gases come out. We're going to make the incision a little bit bigger. No, don't just use your hands. No, big finger in there. That's it. That's what we need. I'll just open that a little bit as well. Okay, so we've made an incision. Now we need to protect the wound with something called an Alexa. So we put that in here. This protects the wound from any tumour cells that might just attach itself and grow. So we're just going to do that. Here we go, and keep going. Yeah, so obviously Tim has a tumour. We're not sure whether it's cancerous at the moment. We will treat it as a cancer. We'll treat it so that we can cure it if it is, but hopefully it will be benign rather than malignant. So I'm just going to just now see where I am with this. Can I have this, please? Thank you. I'm just going to now just find where I'm supposed to be. Release that. And now we know that we've attached this already. I'm just going to bring out very gently, take that, just bring it out the bowel, and quite a lot of it onto the abdominal wall, as you can see here. And that's quite a lot coming out here. There'll be more coming around the corner here. Perfect. So I'm just going to take that out of the way for a second. Now, so let me just orientate you all through this. Here we go. Just put that down there for me. That's just nice and fibers there. Okay. So this is how the bowel was, I guess, attached to the abdominal wall right at the back. We saw the appendix at the beginning. The small bowel is this bit here, the small intestine or small bowel coming in into the large intestine, where the appendix is, going all the way around the colon. This was the bit that was attached to the liver. It will come all the way around. And the vessel we ligated was here. This was a big vessel here, which has all the, what's called the lymph glands. And this is where often we find some tumour cells. So that's pretty good. So what I'm going to do is take out that section from there to there and resect it all together now. So what we're going to do now is do the large bowel first. Take that for me. Can we have 2 betting soap packs, please? Thank you very much. And the other one, please. Thank you very much, Pam. Lovely, thank you, Pam. Great. Okay, so this is now going to be resected. So if you just hold that there for me, Arti, give me that for me. Just let me go here. Just take that for me. Okay, let me take the hands. Okay. So just gently, I've got plenty of length here, so we'll just go back here. I think that's just around the hepatic flexure, which is here. So it's about here, isn't it? Just hold that stretched out for me. Get that stretched, the fat stretched. Okay, here we go. I'm just going to gently tease the fat off to find the artery supplying this bit of gut.
Small foot, please.
So I'm just going to now just open that there. Okay, now let's have some clips, please. What we do now is we check the integrity of the blood supply to this bit of bowel. So
Scissors, please.
if you just cut for me, I'm just going to just hold that there. Yep, cut that for me. Okay, so if you look at that, good blood supply. Beautiful, okay? Thank you.
I can't quite believe what I'm seeing. How do you know, as a surgeon, how much of the bowel to take off?
So this operation is very standardised. Shafi is already taking the main artery to this bit of bowel and the vein from that, and he knows exactly where that artery supplies. So what he's doing at the moment is being doubly sure, belt and braces, making sure that the bit of bowels he's going to be joining back together will have a good blood supply in here.
Ready? Well done, thank you.
I think people can't get their heads around the fact, just looking at social media, that such an important and sensitive organ is sitting on its own outside the body like that.
It's a wonder of surgery.
All right, now let's bring this across here. Take that up there, just gently, just a bit fat, isn't it? Okay, give it up. Hold that up. Hold that up, just do it. Okay. So we need to go about here somewhere. Yeah, we'll get there.
So the operation is now going a lot smoother for Tim. He struggled a little bit with the positioning initially, with all the changes and pressures and stuff, but things are now
So please, Miss.
So things are smoothed out a little bit now. Tim struggled a bit earlier with the changes in pressure and the head down, and so ventilation was a little bit tricky, but it's all looking a lot better now, and we're hopefully on the home straight. Temperature is starting to pick up a little bit more like it should do. We're on target with things like his blood pressure aims and ventilation and all that. And yeah, it's looking good. We're going to sort out his pain relief and get him ready to wake up soon enough.
Scissors, please, scissors.
No, that's
Feels that way?
yeah. This is the tissue.
What's that? Is that tissue? Or is
Yeah,
it?
it's a mesenteric tissue.
Is it?
Yeah, I think we can pause it.
That's fine. Good, please. Just get that controlled. I think you're right. I think just underneath it and tweak. I think you're right. Yeah, keep it dry, thank you. Scissors, please.
Thanks.
1 second, diaphragm again, please.
Jamie Murphy, what's happening now?
So Shafi has already fully mobilised the bowel from the connective tissue when he was performing the laparoscopic surgery. But the bowel, small bowel and the large bowel are still attached by fat. He's currently dividing the fat and just securing it so the bowel is totally free.
And how straightforward will it be actually getting the tumour out?
The way things are going at the moment, it's going very smoothly. I don't think there's going to be any major issues from this point.
Tab, please. Yep. Ready? Okay.
Yeah, thank you.
Thank you, Arti. Good. Thank you very much. Cut, please. One more go. Okay, good. Tie these as well for me.
You have this. You must have this. Just give me 1 second.
It's very intense in there, but it's very relaxed, but you can't get too relaxed.
Of course. No. And Shafi will be thinking several steps ahead of what he's doing at the moment. It's going well, but there's always a possibility that something could be encountered that's unexpected.
Yeah, for sure. The team have to be ready to react to any situation that arises.
Good. We're doing well. So you can be doing fine during the operation. It's all going swimmingly well. But very suddenly, and this is milliseconds, seconds, things can change.
Any mishap could potentially turn life-threatening.
It may be that the surgeon has seen something that they weren't expecting, that I see something I'm not expecting, and usually one of us will be the first to then have to alert everybody else to the fact that something is taking place here that needs everyone to focus, that needs a different course of action to suddenly be taken.
The atmosphere in theatre changes quite palpably. You very quickly fall into a routine of, OK, guys, let's focus now. Let's focus for the next 5-10 minutes. Make sure we get through this bad patch and back on track again.
The main thing is to be calm because you're trained to deal with it. So that's when the role of a senior person or a master comes.
Always think about what's best for that patient. What's the best outcome I can perform given the fact this is what I'm dealing with in front of me. And that's the kind of thing that we've learned over many, many years of hard graft, many hours working, both in day and night, trying to make sure that during stressful situations, we are confident and competent and able to deal with situations that arise in front of us. Thank you very much. Not quite yet. Thank you. Here we go. Just got that little bleeder. So control it adequately. Tie that for me. Just tie that. Cut the other, carefully. Thank you. Yep.
Cut the thread, please. Good.
Thank you. Now stapler ready, please. Cut that for me. Thank you. Thank you. That's a needle. Right, stapler, please. Endo-GA. So now we're going to get a stapler here. Thank you very much.
Just a plain G.
So I'm just going to go across here. So the stapling device, again, this allows us to go across the bowel. Just wait for a few seconds for it to be pressurized, and it's good. And this allows the firing of 4 rows of staples, 2 either side, and cuts between the 2 of them. So here we go. Just wait a few seconds, make sure that the tissues are compressed enough. Now we're going to just fire the staple across. And that's taken the, let me show you that. That's resected the bowel, as you can see, either side, and it's closed. Same on this side, please. Let's go. Thank you. And again.
GI.
Both together, please. Thank you. Thank you, Arthur. Thank you very much. Okay, we've restapled. 1 second. I'm just going to go around here somewhere. This is where the vessels work. It's got plenty of space, so let's just tie that little bit there. Tie that for me. Just get rid of that again. Yep, this bit here. Arthur, just one. Okay, hold that for me now. We'll now just angle that slightly in this direction. Into space there, and very good. Same thing, we've applied that through the large colon now. We've taken the small bowel, and that's the large bowel. We're just going to wait again, compress it for a few seconds, and then we'll staple again. And we're ready to fire, and there we are. So now we have, hopefully, the resected bit, which we'll show you in a moment. Can that go off, please? The specimen, please. Thank you very much. Good. 1 second, that's fine. Yes, so if you just, remove the tumour area. Now we're left with the 2 bits of bowel we need to join now. Diathermy, please.
Right, let's look at how Shafi rebuilds and rejoins the bowel so that it continues to function. Shafi will line up the 2 healthy ends of the bowel and then make a small cut in each end. He'll use the surgical stapler to bind the 2 ends tightly together. The stapler's built-in knife makes a hole between them to make one continuous tube that food can pass through. The open ends are then sealed by a row of staples and stitches, and the repaired bowel is ready to go back in the body without the tumour.
Okay, I'm just going to hopefully now do the join. Okay, so let's have some Babcocks, please. the right way round. See?
This is twisted. So it should be.
One second, one second. Make sure we haven't twisted anything. One second, one second. Make sure we haven't twisted this thing. Just show me. So that's that. Is it this way? Just check. Let's put it back in. Let's see which one is it. No, let's just see. That's good. Let's just lift up the whole thing there. And that's that. That's good. It's this way. Okay, let's get that ready. So put that around here for me. Let's have 2 soft bow clamps, please. No, we're happy. Look. That's all the edge.
Sure.
Yes? Okay. Just going to pop that in there. Okay, soft bow clamp, please. Thank you very much. We're going to just pop this in here. Just relax. Just one click there. And the large bow again, just to control it. Another device which just compresses a little bit. Perfect. Now we're going to join this bit of bow, small bow to the large bow. Let's have the Babcock, please. Let's just have a diathermy and a pair of forceps, please. And a pair of forceps. I'm just going to just dissect this off a little bit because it's just a bit stuck around here, isn't it?
How was this operation performed before keyhole?
Before keyhole, we would make incisions, cuts in the abdominal wall, up to 30 centimetres in order to be able to mobilise the bowel fully. Obviously, now we have keyhole, we make these small cuts that allow us to free the bowel and then deliver it through cuts only 1 or 2 inches.
So before, was it far riskier?
It was certainly a longer recovery, and the patients had more risk of having scar tissue inside that might cause them trouble in later life, or hernias through the cuts for the surgery.
What's going on now?
So Shafi is currently preparing the bowel. This is the very critical component of the operation to make sure you're joining the bowel together, healthy bits. And Shafi just has to be 100% happy with this bowel joint, so the patient recovers quickly and does well.
Yeah, maybe you're right.
One side.
Okay, so now we're going to do the joint. So what we're going to do is, let's take the small bowel first. Scissors, please. We're going to make a cut into the small bowel to let the access the. Oops, that's a good vessel there. Can we just get a diathermy, please? Just give it a swab for me, somebody. Thank you. And again, just there. I've got it. Just spurt it there. There. Got it? 1 second. Okay. I'm good. Okay. Just give me that one more once again. Make sure that we've got control. It's just. Okay. Very oozy, isn't he? Okay. And now the other side, please. Babcock again, please. Thank you. Show me. Scissors, please. I'm going to just cut this now across here. And again, it's oozy, isn't it? There we go. Take that. Give that back to Pam. Let's just control that a little bit. Are we in? We are in. Just there. We're in. Okay. Right, stapler, please. Mind your hand. Hold it there. Okay.
Inside.
Just put that in there.
So what's the next big step?
Okay, I'm going to
So
pop
the next big
stapler
step
into
is
each
that,
bit
as
of
you saw in the
bowel. So this
graphic,
is going to go
Shafi
into
is going to
the
join
here.
these loops of bowel.
Take that for me. Hold that. George or somebody. George, hold that. And the other part into here. I'll just get in there. There we go. Good. Perfect. So now I'm going to relax 1 second, George. I'm just going to turn that around. And we're going to just bring that bowel all the way up. Here, 1 second, 1 second, 1 second. Get the Babcock in there, Artie, and rotate it for me. Go right in there. Go right in there. Go in there.
Thank you.
And like so. Grab it, push it down. Okay, go down a bit further so you're in the way. Okay. Relax. And rotate it for me slightly. That's fine. That's good. That's good. That's good. That's good. So just align that perfectly. Right there, just a bit more. So I can just do that a little bit there. Okay, so what we've got now is this bit of bow is going to be attached to this bit of bow. Okay, you happy with that? Arti? Just check. Just check your side. That's good, I'm happy. Good, let's just wait a few seconds. What this will allow us to do, that join will join onto this, so the small bow will join the large bow. There'll be staples fired across it, and there'll be a cavity so things can flow through both together. So I'm just going to wait a few seconds. This allows compression, allows the bleeding to be controlled. I'm just going to fire it now. And then we just gently give that to Pam. And now obviously we're inside the bow, so we've got to be very careful about contents being spilt. Hold that for me. Another stapler. Now we're going to staple right across the top to seal the hole that we've made. Hold that for me. No, it's fine. Hold that. Just hold that. I'm good. I'm just hold that. I'm going to go below that. You happy with that? That's okay. Hold that. And hold that. Arti. Oh. Arti, you hold both. Good. Now we're going to reload, please. Now what we'll do now is to seal the hole, is to go right across both together. Show me. So we've got, show me, I can't see the hands up there. Right across everything.
Does that stapling, Jamie, have to be done at a certain angle?
So what Shafi's doing is making sure that there's no spillage. So yes.
Well, very soon we're going to see the bow being put back into the body by Shafi.
Dry swab, please. Medium size. I've got it here.
Get new ones.
Put that in
new
here.
socks, please.
Yeah, just go those out of the way. Thank you. Just gonna make sure it's all dry inside. It's a bit oozy, isn't it?
Jamie, if the two parts of the bowel, for whatever reason, don't take, or the stitching is not done properly, what are the implications for the patient?
This is a colorectal surgeon's nightmare. Essentially, this is when you have a leak from the joint, and
Same one
more
again,
often than
please.
not, that will
Last
mean
stitch,
that the
PDS.
patient will require a second procedure. That might be a scan and a drainage of
Tomato,
some
please,
infection
tomato.
through a needle, or it may even mean going back to an operating room to have a bag fitted for 3 to 6 months. That's why Shafi's taking such great care doing this.
A lot of people watching this with us want to know how the instruments are kept sterile.
So there is a very specific hospital process for this, and all reusable instruments go through this. The disposable instruments themselves are sterilised in various different ways, and they come from a manufacturer already sterilised.
And the bowel will function as normal after this is all over.
Once the patient settles, so in the next 2 to 3 days, the bowel will begin to function, and eventually it will start to go back to close to where it was.
What's eventually?
Usually about 6-8 weeks, the patient's bowels will have regulated and gone back to close to where they were before.
And if that were to be the case, what's the maximum amount of bowel that you can remove?
That varies depending on the condition, and so that's a difficult question to answer. But certainly in this operation, we've removed the right side of the large bowel, and the patient won't, Tim won't notice much of a difference because of that.
Can we have those gloves, please? Take those. Let's have a change of gloves. We're not going to put. So now, where we are now, we've joined the bowel together. As you can see, that's the joint here, and the bowel contents will flow from the small bowel into large bowel through the joint. We've stapled it, we've oversewn it with more stitches to reinforce the whole area. Now we're just going to pop it back into the abdomen. So all we do is lift this up and just let it flop back in, just very gently through that tiny hole that we made. And there it goes, back into the abdominal cavity. We're then going to just have a look, make sure it's all okay inside by placing, can we open one? Just open once. Open once. Good. Okay, and just put that across here. That'd be helpful. You've got it, Arti? Thank you, Arti. Can you help us on this side? Good. And now I'm just going to change my gloves. 6.5, please. And if I can come around the other side, please.
I don't know if you're fully aware of this, Jamie, but that is astonishing.
For us, obviously, we do this operation very, very frequently, but yes, I see where you're coming from, sir.
Yeah, when you stand back and look at it.
Yeah.
There's a lot of people involved in the whole process of considering, for example, Tim's operation.
Yes, there are indeed.
How for time?
So obviously, Tim has presented to clinic, he's been seen by doctors, he's been assessed, he's been sent for investigations, colonoscopy, CT scans, which have given us the diagnosis we have at the moment. And then his case has been discussed at a multidisciplinary team meeting with all of those professionals present.
Okay, good. So the MDT stands for the Multidisciplinary Team Meeting. What it is that we get a group of clinicians together, that's radiologists, people who read x-rays and CT scans, oncologists who often give patients chemotherapy or radiotherapy, pathologists who diagnose the cancer, nurse specialists, palliative care team, and all the surgeons and doctors involved in the care of the patient. It's designed to ensure that we're making good choices for our patients.
There is so much of expertise in the room, like consultants of different specialties, and everyone brings their own special skills into the room, into the decision making.
The nurses might have met, like Ronnie and I met the patient, and we might say, you know, they're so frail and would they be fit for surgery? But everybody comes together with their expertise to ensure that the plan for the patient is the best outcome.
I think we should see him in clinic urgently, really. Okay. It really enables us to give a world-class treatment. That's personalised, it's individualised. Each patient has the correct treatment. I'm going to pop the camera back in now. This is just a last look to make sure that we haven't done any damage, there's been no bleeding. So I'm going to pop it back into the abdominal cavity. We'll have a gentle look as we were, and you remember the anatomy earlier. The liver is over here, the stomach's over here. That's where the joint is. Can I just have a Johan, please? Thank you. Can you get a swab and just give that a squeeze?
Small swab, please.
Also just give that a squeeze. And Johan, please, Johan. Come to Johan to me, please. Just going to gently have a look. Just warm it again. It's gone cold again very quickly, as it always does. Let me just have a gentle look. Make sure the join's okay. And there's the join here. There's the stitches you can see across the bowel there. All joined nicely between the two. Okay, all we're going to do is make sure there's no obvious bleeding there. We're going to check. It's all pretty dry. Just give me a suction there. Suction a little bit of blood at the top there. No, it's okay. Just give that. Just going to just go right in there and just suck out that little bit of blood, tiny drop, to make sure it's all clean. Let's give it a bit of a wash there. Make sure. Just make sure we just wash that out. Okay, that's good. I'm very happy with that. Take that a bit of just around here, which is just a bit of fluid up in, just here. Just here. Make sure it's all clean. And I'm pretty happy with that. Make sure there's nothing in the pelvis. Just a little bit there. And that's pretty good. So I'm very happy with the outcome of the operation so far. Nothing untoward. It's all been fairly good. There we are. I'm just going to get the Johan again, please. And we're going to put just the fat that we had earlier, just over the top of the abdomen, like so, across the join, like so. It's just to protect it a bit further in case there's a problem. And there we go. We'll get that bit of a clean. And now we're going to take out the camera. There we are. We're going to release the gas. Take that for me. And then release the gas. And decompress. Stop the gas, please, everybody. And we're going to now just take all the gas out.
Closing time.
It is indeed.
The gas is a fascinating part of this whole operation, blowing it up to give you more room.
Yeah,
Exactly. So Shafi has been pumping in carbon dioxide, so he has a greater view, separates the tissues apart, and so you can see better. We're using carbon dioxide because it's reabsorbed by the patient's body much faster than air or oxygen is.
I guess on the way through, if you smell anything unpleasant, you've got a problem.
We're always alert to that. So if there is an unpleasant odour, obviously we've been operating on the bowel, we need to double check that there isn't something we've missed.
Just tell us what's going on right now.
So what Shafi is now doing, he's removing the ports, the access points he has. He's now looking at the wounds themselves, checking there's no bleeding and getting ready to close these incisions.
What's your peer-to-peer review of
Very
this
good.
operation?
Very good.
And the scrub nurse?
The whole team have been fantastic.
What's the scrub nurse doing right now?
A scrub nurse will soon begin discussing and checking that all the instruments and the swabs are correct, and we'll hear that soon.
2, 3, 4, 5.
You can already hear the counting.
Yes, we had this last night.
Small.
Strangely reassuring.
It is. Everything that's been used has to be counted out.
1.
So this is the specimen that we removed during the operation. So if you orientate you properly, this is the small bowel just in there. We took a small section of that, and that feeds into the large bowel. And this is the appendix that you see here, just hanging down here. And that's the large bowel going all around here. And as you see, we've taken the small bowel here and large bowel there and joined the two together. What's more important for these operations is all this fat. This is where we get the lymph glands, that if it is a cancer that we're dealing with, then they can go into these lymph glands here, and our pathologist will take this, slice it up, try to find what's going on, not only of the tumour here, but also here. And if I have a gentle feel, I can feel a small lump just in here. It's small. It's not big, just here. And hopefully this will be benign, but you can just feel it just here. And you can see a slight indentation where that little tumour is. And let's just hope it's all benign for Tim. If not, it's still very early, and I'm sure he'll get a really good outcome with this operation.
4.
So George and Artie will now close. We're going to pause for gauze to make sure that we are correct. So Pam's now counting furiously to make sure that we haven't got any instruments left behind or any swabs. And then George and Artie are now going to close the abdomen. Artie will close the deeper layers, and George will do the finishing touches to make the scars look really attractive.
Yeah.
What for God?
Make the scars look really attractive.
Indeed. Ultimately, that's the only part the patient will see. If that looks good, they assume everything that's done inside has been good as well.
Did you have a mentor?
I had several
I'll be
mentors
carry
through
on.
my
We're just
career.
waiting for
Very
applause,
important
of
to
course.
your
So
development.
just wait a
Well,
few
George
seconds
has
till
learned
they're-
so
are you
much from
happy,
Shafi.
Bafta? Let's just make sure we count.
Being able to close a wound at the end of an operation is like gold dust for a senior house officer or someone at my stage of training. It's your chance to take the reins and actually get your hands on the equipment and work with the scrub nurse, work with the anaesthetist, and begin to take that role primarily doing something in surgery. It's very exciting.
So George is my junior trainee. He's young, he's fresh-eyed, he's enthusiastic, he wants to change the world. He also wants to get his hands dirty by doing simple operations.
It's so important. It's so refreshing to see, where you were 10 years ago, how I was like learning to tie the knots and learning the dissection, always willing that whatever the main surgeon would leave, we would love to get our blood on the hands.
You get a brief taste of being a surgeon in those moments. And all of a sudden you've gone from holding onto a piece of equipment at the side to actually under the spotlight, and it makes a huge difference.
Seeing people like George just give me a kind of new lease of life. I look at him and think, great, you're going to be an amazing doctor in the future, and I'll try to share my skill sets with you, what I've learnt, share my knowledge, because ultimately he's going to be the future of our profession.
Well, in a few moments, we're going to find out how Kamal is covering. We watched his heart surgery on Tuesday night, and also whether Howard is up on his feet following the knee replacement surgery last night.
I didn't just know whether.
I love that.
So I'm very pleased with the operation. It's gone really well, actually. We came to... So the operation went well, very happy with it. We've taken away the tumour with a big margin of tissue. We've controlled everything nicely. I hope this is going to be a cure for Tim either way. We'll send off the specimen for analysis, and then we'll obviously wake him up, take him to the high dependency unit, give him in hospital for 3 or 4 days, recovering fairly quickly, I hope, from a fairly good and short operation, and hopefully we'll then see him in the clinic in a few weeks' time. So we're very pleased, and the team's done an amazing job to ensure that he was safe during the operation, this anaesthetist and the scrub nurse and the team combined.
Well, as George and Artie finish the procedure on Tim, it gives us a chance to look back on an amazing, an extraordinary 3 nights of surgery and check in on the fantastic teams and the patients that we've met. Now, last night, we witnessed Mr. Steve Millington give Howard a complete knee replacement. For some, it was a bit gruesome, but it was absolutely compelling. An operation that could well absolutely transform the quality of his life. Howard was given a spinal block, numbing him from the waist down. He was awake for the whole procedure. Orthopaedic surgeon Steve Millington cut away those sections of bone with worn cartilage.
So just here is completely worn away. So this is what causes that sharp pain and stiffness, and that will be like somebody sticking a sharp knife into the end of his bone.
Then Steve cemented implants into Howard's thigh and shin bone.
Right, that's your leg, and it's all pointing in the right direction. Look, you can bend your knee up all that way without any difficulty. Okay? All good.
Well, they're still sewing up in Theatre 2, but that knee operation that we saw last night was a great success, and Howard is recovering on the ward.
The operation was quite surreal. Might be to do with the fact I was listening to Pink Floyd's Dark Side of the Moon and the Beatles' White Album, mixed with whatever the anaesthetist was supplying me with. I was aware of what was happening, but in a totally non-panicky way. I could definitely hear some hammering at some point, which did sort of sound like someone was doing some maintenance somewhere. But I guess that was my knee getting a good bashing.
1, 2, 3.
I'm really looking forward to starting the physio and getting on the true road to recovery.
Perfect.
Okay.
And you're up.
Yeah.
That's great.
He was listening to the White Album by the Beatles. I hope it's the remix, which is excellent. Pink Floyd, what excellent taste he's got. Now, on Tuesday, Howard, on Tuesday, we were lucky enough to see life-saving open-heart surgery. Images I will never forget. I felt really privileged. I know everybody who watched the surgery felt the same way to watch it. It was mesmeric, and it was fantastically impressive as well. And a hugely important and wonderful resolution to a naturally worrying period in his life. We are joined by Mr. Kulvinder Lal, who performed that operation. First off, the teamwork. I just want to ask you about the teamwork. Amazing.
It's a big operation. It can't be done by one person. So the entire team is very important. So from the anaesthetist, the perfusionist, to the nursing staff, and also to all the nurses on the wards and the pre-admission clinics, it is a team effort.
Let's remind ourselves what happened.
I'm going to be happy that I get it done once and for all, because once they do it, I'll be okay.
I just want you to know I'm here for you and that everything's going to be okay.
I'll see you soon then, yeah? And take it easy, you hear me?
Love you.
All right.
Hello, sir. All right? Okay, do you remember I'm Claire?
Lead surgeon Kulvinder Lal opened Kamal's chest, stopped his heart, and removed a faulty heart valve.
So that's 2 of the leaflets, and you can see it's like a solid rock there.
Kulvinder replaced the valve.
And what we're going to do is just parachute gently the valve down into the aorta.
And we saw the incredible moment when his heart was restarted.
This operation's gone very well. Kamal's going to do very well out of it.
So, Kulvinder, how is the patient?
He's done very well. He was extubated, which means the breathing tube was removed about 4 hours after the operation. So that was about 4 o'clock in the morning, yesterday morning. He was stepped down to the high dependency unit, which is one level down from the intensive care unit this morning, and tomorrow morning he'll be going back to the ward. So he's done very well.
Was it an absolutely straightforward operation, or are there any differences or any slight challenges?
The only thing we had was that his valve was quite badly diseased, so that initially when we gave the cardioplegia to stop the heart, we normally do that through the a cannula into the aorta directly. But because he had quite a leaky valve as well, we had to open the aorta and just deliver the cardioplegia directly into coronary arteries. So it happens in about 20% of aortic valve replacements.
So absolutely well used to dealing with
absolutely,
it. Very much in the mainstream. So how is he feeling now physically?
So he's fine. I saw him this afternoon. He's a bit nauseated from the anaesthesia, but he's sitting up. He's sitting out of bed, and he's feeling pretty good, actually. So if he wasn't feeling so well, we wouldn't send him back to the ward tomorrow. But
what kind of pain is he getting?
So he's getting some pain from the wound, but he's on a morphine infusion, and that should take care of that. And we'll keep him on that for about 48 hours or so, and then step him down onto things like paracetamol and tramadol. And then we'll start getting him mobilised, and once they start to mobilise, the pain sort of disappears fairly quickly.
Yeah. So, I mean, it's amazing stuff. It really was.
That's great. I mean, you know, it's a job that we love, and if you speak to most cardiac surgeons, they really enjoy their job. So it's great for us then, and it's great doing something that you really enjoy.
It's so precise and intricate.
Yeah, it is. It is. But you know, the training process is very, very long and very selective. So really, you know, only if you've got the hands do you eventually get to become a consultant in cardiac.
How many operations can you perform in a day?
So generally we do 2 operations a day, but then generally if we're on call, and it's somewhere like the Barts Heart Centre where we do about 2,500 cardiac operations every year. When you're on call, you can generally do 1 or 2 operations in the evening as well.
Thanks, Govinda. Well, that's about it. That's all we have time for. Huge thank you to all the staff at Barts Health NHS Trust, St Bart's, and also the Royal London Hospitals, and of course to the patients. It's been an extraordinary privilege to step into their world and to see at first hand the people that make these life-changing and life-saving operations. So we'll leave you with a few shots of Theatre 2, and from everyone here, thank you for watching Operation Live, and a very good night.
Yeah, it's okay. Looks good, George. Scissors.